In today's Explainer, we are diving deep into a really common clinical challenge. How do we get from diagnostic uncertainty to a clear, evidence-based plan for managing chronic asthma in kids under 5? This is all about giving you a confident, structured protocol for your youngest patients.
So, this is the big question, right? The one we all face in the clinic. A little one comes in, wheezing again, and you're thinking, is this just another bug going around, or are we looking at the start of persistent asthma? Making that call early on, it's absolutely critical for their long-term health. So let's break down exactly how to do that, step by step.
To get to the bottom of that, we're going to walk through a clear 5-step clinical pathway. We'll kick things off with the diagnostic challenge itself, introduce a really key predictive tool, then we'll get into the initial and escalated treatment plans, and finally, we'll pinpoint those exact moments when a specialist referral is the right move.
All right, first up, let's just frame the problem. In this age group, wheezing is incredibly common, and a lot of the time it's just transient. So the real challenge isn't just spotting the wheeze, it's figuring out which of these kids are actually on the path to developing persistent asthma down the road.
The goal here is to move past that reactive kind of wait-and-see approach. What we need is a standardized, evidence-based tool that helps us stratify risk and lets us make a confident diagnosis much, much earlier. And you know what? That tool exists.
And that brings us to the Asthma Predictive Index, or the API. For this specific age group, the API is really the cornerstone of our entire diagnostic protocol.
So what is it exactly? Well, the API is a clinical prediction rule, and it's designed specifically for kids between 2 and 5 who have a history of recurrent wheezing. Its whole purpose is to identify which of them are most likely to have persistent asthma after they turn 5. Now, before you can even use the index, there's a prerequisite. The child has to have had 4 or more wheezing episodes in the past year. And, this is key, at least one of those episodes has to be documented by a physician. This frequency filter is the first step.
Okay, so let's say the child hits that frequency mark. What's next? Well, this is where the API gets specific, using a mix of major and minor criteria to figure out the risk. To get a positive API, you're looking for just one of the major criteria, things like a parent having asthma or if the child has physician-diagnosed atopic dermatitis. If you don't have one of those, you'll need 2 of the minor criteria, and those include things like wheezing even when they don't have a cold, certain allergies, or a blood eosinophil count over 4%.
So the formula for your clinical practice is pretty simple, but really powerful. 4 or more wheezing episodes in a year, plus either 1 major or 2 minor criteria, that gives you a positive API and a working diagnosis of chronic asthma.
All right, you've used the API, you've made the diagnosis, now what? Let's walk through the initial first-line management protocol for a child you've just diagnosed.
This initial therapeutic trial is very straightforward. You're going to start with a low-dose inhaled corticosteroid, an ICS, twice a day. You'll also prescribe a short-acting beta agonist, like albuterol, for rescue. You continue this regimen for a trial period of 8 to 12 weeks. And here's the interesting part. If the child shows significant improvement, you can actually stop the controller therapy and just schedule a follow-up in 3 months to see how they're doing.
Of course, it's not always that simple, is it? Not every patient is going to respond perfectly. And this brings us to a really critical decision point in the protocol. What do you do when the child just isn't getting better?
Now, before you even think about escalating therapy, you've got to go back to the basics. This is so important. First things first, check their inhaler and spacer technique. Really watch them do it. Second, what about compliance? Are they actually getting the medicine as prescribed? And third, you need to play detective a little. Are there any environmental triggers at home you might have missed? You have to tick these 3 boxes before you consider changing up the meds. So, let's move to the next phase. This part of the protocol is for those kids who either see their symptoms come roaring back after you stop therapy, or for the ones who didn't respond to that initial trial even after you did all the troubleshooting.
For the child who got better and then relapsed, the guidance is crystal clear. You just restart that initial protocol, the low-dose ICS and SABA, for another 12-week course. It's also worth noting that during this period, you could consider titrating up to a moderate ICS dose if you feel it's needed before you try to wean them off again.
Okay, but what about the patient who just didn't improve on that initial protocol? The next step up is to add a leukotriene receptor antagonist, an LRA, to their existing ICS and SABA regimen. You'll continue this 3-drug combo for another 8 to 12-week trial, and then you're going to reevaluate to see how they've responded.
And finally, a really critical part of any good protocol is knowing its limits.
and knowing exactly when it's time to phone a friend and bring in a specialist. So let's cover the specific triggers for referral.
There are two really clear triggers for referral. The first one is if the patient fails to improve on that initial ICS and SABA regimen, even after you've thoroughly checked their technique, their compliance, and all those environmental triggers. The second and more definitive trigger is a lack of improvement after that 8 to 12-week trial with the added LRA. In that second scenario, the protocol is explicit. You stop the LRA and you refer the patient to a pediatric pulmonologist or a chest specialist.
And that pretty much wraps up this structured pathway. By using a predictive tool like the API, and then following a clear, stepwise plan, we can all bring a lot more consistency and confidence to managing this really common condition. So, the final question to think about is, how could a protocol like this standardize care and improve outcomes in your own practice?